from the American Academy of Pediatrics.
60% of liver transplants in infants are caused by biliary atresia.
The AAP has a new clinical report that outlines how to detect this critical condition in newborns.
Even though it's a complicated disease, it's a high-impact disease, the collaboration between primary care doctors and specialists can really change the course of a child's life.
Plus, a new article looks at variations in pediatrician work hours.
We were really interested in seeing not just how many hours people worked, but that was important, but how that changes over time.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a discussion about detecting biliary atresia.
There are so many well-child visits in the first year of life, a lot in the beginning, and then they space out.
Yeah, I think at last count there are like 7, which is a significant amount of time in the office. It gives you time to get to know families and do a lot of anticipatory guidance and checks on a baby.
Around 3 of those visits can be just within the first month of life. I remember the post-hospital visit and the 1 to 2 week weight check for my first baby. Luckily, all my kids are healthy, so those visits were routine.
But it also gives us a chance to pick up on things that aren't routine. While jaundice, for example, is super common, some forms of jaundice are not. Biliary atresia can cause jaundice and cause liver failure, so it's something we never want to miss in practice.
And those kids can be asymptomatic, so they might not end up in the NICU with me. That's why I'm happy the AAP put out a new clinical report identifying infants with biliary atresia by 2 to 4 weeks of life, guidance for the primary care provider. Here to discuss are 2 of the authors on this report, Drs. Sanjiv or Sunny Harpavat and Saul Karpen. Dr. Harpavat is an MD, PhD, and an associate professor of pediatrics at Baylor College of Medicine. He's also a gastroenterologist specializing in liver diseases.
Dr. Saul Karpen is also an MD, PhD, and is professor in the Department of Internal Medicine Division of Gastroenterology and Hepatology, an adjunct professor of pediatrics, and the chief scientific officer for the Stravit Sanyal Institute for Liver Disease and Metabolic Health, all at the Virginia Commonwealth University School of Medicine. Shortly, he'll also be president of the American Association for the Study of Liver Diseases. Sunny and Saul, welcome to the show.
Thank you for having us. Thank you.
Thank you. This is really an honor. Appreciate it.
Thank you for joining. And David mentioned biliary atresia can cause liver failure in infants. Saul, how common is biliary atresia, and do most of these children wind up getting liver transplants?
Great questions. So in the grand scheme of being a child, it's extremely uncommon. Probably somewhere between 1 in 10,000 to 1 in 18,000 births may have this particular diagnosis. So it is, in the grand scheme of things, uncommon. In liver disease, however, it's quite common, and it actually ends up being the number one reason why any child will need a liver transplant, and it is also the number one reason why any child will need any transplant of a solid organ before 1 year of age. So although it seems rare, it's quite common. There's probably about, and this is a educated guess, probably about 500 kids a year in the U.S., give or take 50 or to 100, that have biliary atresia each year. And it is only a disease of newborns. It is not something acquired. It's something that you're born with. So seeing that we are now talking about new screening guidance really puts us in what I would say we as pediatricians do really well, which is think about the future and think about what we don't want to miss. And this is one of those diseases we don't want to miss.
Well, I really appreciate this clinical report because it gives primary care pediatricians 3 simple steps to the diagnosis of biliary atresia. The first is looking for jaundice, which we know from our 2022 clinical practice guideline revision can be hard for pediatricians to see with the naked eye. So, Sunny, what's the most evidence-based way to make sure we don't miss pathological jaundice in the office?
Sure. This is a tough challenge. We have primary care doctors who see hundreds, if not thousands of patients each year. We're asking them to be the front lines to pick up a disease that's very serious. And if they catch it early, they change the trajectory of a child's life. And unfortunately, and I think many in the audience might know a story of someone who couldn't catch it early and how devastating that can be for some families. Jaundice is jaundice. So yellow in the eyes, we like to look in the eyes as opposed to the skin, so it's not as confusing. It's a little easier to see. But jaundice is jaundice, and the AAP is very good about red blood cell causes of jaundice, unconjugated bilirubin, and need to do phototherapy. And this is Dr. Kemper's hyperbilirubinemia guidelines that you referred to that are widely used, and really the basis for bilitool.org, which is also widely used. The problem with that is the jaundice of biliary atresia and liver disease matches the jaundice of the other type perfectly. And so now you can imagine primary care doctors have this incredible challenge, almost an impossible challenge, I would say, of distinguishing which children are the ones with liver disease amongst the many, many, many more children that are jaundiced without liver disease. So the challenge here is jaundice is jaundice. There's no way to distinguish jaundice in a child with biliary atresia from a child with, let's say, breast milk or breastfeeding jaundice. So really here, if jaundice persists for 2 to 3 weeks of life, as outlined in this clinical report, that's when we should start worrying about causes like liver disease. And so the reason why we did this clinical report is we've now tried to equip the primary care doctor with some tools to help make that decision point, that detection.
So, Saul, what's the most evidence-based way to make sure we don't miss pathological jaundice in the office?
I think it's hard. I think, number one, it's easy to miss completely in newborns. And I know in the NICU, we have the luxury of also getting blood work, which I think is really the educational aspect of this whole guidelines is that we miss things just based on our eyes and our experience. And some of it is just children don't open their eyes, number one. Number two, we don't always spend a lot of time looking at our kids when it's light in the room. So we don't always see this as parents. And thirdly, we really have different colored skin and eyes that it's easy to miss. So I know we're sort of talking about something that we're using as the first clue, but we're so used to picking up jaundice. There were actually great data from about 20 years ago and 10 years ago about how we really miss jaundice at levels that one would think you're supposed to pick it up. So, for example, most of the kids with biliary atresia that we see, their total bilirubin levels are in the 5-6 range. It is not, as one would think about, when you have liver disease, you would say, this is a kid with liver disease because the bilies are higher. They're 10, they're 15, and then when we do the direct or conjugated, we see that. It's actually not true. So it's a subtle amount. So almost any jaundice is really, unfortunately, I think, the advice I would give to then think about the next step. What Dr. Harpavat was talking about was duration of jaundice. And all of us have seen kids and know of kids, even maybe our own kids, where the jaundice has persisted beyond 2 weeks of age. And it's actually a small percentage of kids where that actually is true. And so it isn't as common as people would think or as easy to pass off. So I would say that it's not only the ability to see some jaundice, our ability for the ocular bilirubinometer, basically, where we think we can say, here's a level based on the degree of jaundice that I personally see, is really a false equivalency. We can't tell how high the bilirubin is based on the degree of jaundice. And so I would say that you use this as your first almost hint that you do need to think about whether or not there's an investigation in your future based on seeing any jaundice. And yes, starting with scleral icterus is the right way to go.
And that leads us to the second step, which is looking at stools. Now, when you get pediatricians together to talk about stool, we could go on for hours. But Sunny, can you summarize this step for us? Is it easy to do in a busy outpatient practice?
Yes, it is actually easy. If a child produces stools, you look at it. And if it looks pale, that's a source of suspicion. There's all sorts of charts available, including in the clinical report, because stool has a gradation. So some look more pale, some look more colored. There's apps available, which are listed in the clinical report as well. And then parents as well as primary care doctors can use this to check for stool color.
Step 3 deals with checking direct or conjugated bilirubin levels, asking if they were already checked in the past, and then knowing if the results are outside the reference range. Sunny, how do we know when those levels are high? That would seem simple, but I guess it can get a little bit more complicated. And can you talk about the first 2 weeks of life and then the next 2 weeks?
Yes. So the step 3 is a step that does require us to address a problem that's endemic in our practice, which is getting information from the nursery. That doesn't always happen fluidly, but in some healthcare systems it does, and it's easier in some than others. But the idea is, as mentioned earlier, biliary atresia is a disease that children are born with. And one of the things about being born with a liver disease is that at birth you have high liver numbers because the disease is already there. And that liver number that many people since and we found is that liver number, the direct bilirubin, is high starting at birth. So it provides a very, very early test to say, this baby might have something wrong with their liver. The baby needs repeat testing, follow-up testing. And so that's step 3, is to check to see in the nursery, did anyone happen to draw a direct bilirubin already? And if so, just make sure that direct bilirubin was normal. If it was high, that would need follow-up to rule out liver disease.
And Saul, it seems like this workup exceeds a little bit of what we normally do for newborns. How do general pediatricians make time for this?
I think it's really an incorporation of thinking about whether or not the child needs further investigations. And so we do not have any better way of knowing whether or not a patient does or doesn't have underlying liver disease other than to get blood work. So I would use that as the alternative answer, meaning certainly one could say, nope, I've seen jaundice before, it goes away all the time, let's just watch and wait. And that certainly is one of the ways to go forward. But the problem with that is that you just don't know. And you can't tell whether someone's jaundice is going to dissipate or not. So I would say that, especially in a busy practice, one needs to think about, I don't want to miss this particular, I would say, disorder or group of disorders. And the way I can provide some solace to myself and the families is to obtain a blood test with a direct bilirubin included. I think it's also not a lab test that everybody uses all the time. And they may think that when you just send or can measure in your office a total bilirubin, that you also get a report of a direct. And that's really, I think, one of the teaching points of this document is that you really have to think about it separately.
Sonny, how do pediatricians bill for this extra investigation?
This was a big issue. The AAP is interested in making sure pediatricians not only catch diseases, but also aren't overburdened by their work they have to do, and as well as fairly get compensated for doing extra work. And so in the AAP, as clinical reports go, they go through a series of long revisions. And it did get revised by groups that really care about how pediatricians can code and bill for the work they do. And so through that rigorous process, we realized the strategy, because it involves more time, maybe more complex decision making, the idea was a separate evaluation and management services can be reported. And this is all in line with the current procedural terminology guidelines and payer policies. So the AP was really tuned to that question and helped craft the wording in the clinical report.
And Sonny, when do we need to refer to a pediatric gastroenterologist? When all these steps are concerning, or can any of them trigger that referral?
So if a child has yellow eyes beyond 2 weeks of life, 2 to 4 weeks of life at that visit, or if they have pale stools, or if there's a high direct bili in the nursery, then the primary care doctor orders a direct bilirubin test. And when that level is high, then the idea is contact a GI, because if that level is high, that child might have liver disease. If that level is normal, there's no need to involve GI. There's no need to do more. You can reassure the parents. The idea is in biliary atresia, and this is the challenge, and it probably wasn't stated as clearly. The challenge in biliary atresia is to get these children to GI and treated before 30 to 45 days of life. So imagine this. Children get seen, like we said at the beginning in the newborn period, then at the 2 to 4 week visit, and then again at 2 months for their vaccines. So we really have a narrow window for primary care doctors to catch these children to get them to us earlier. The reason why is the longer we wait, the more liver damage accrues, the worse off the children do.
Well, I am curious to see how many babies these new guidelines save from liver transplantation. And we like you both to leave takeaways for general pediatricians who are going to go read this report. Saul, let's start with you.
One, I think that I would put screening for liver disease, of which biliary atresia is a number one disease of interest, should be put into the same group of all the diseases we screen for early on. And since we can't use the blood spot cards for bilirubin, it has to be separate. So I would ask that pediatricians think that someone whose baby is still jaundiced at 2 weeks or so of age really warrants, I would say, a firm diagnosis that there isn't underlying liver disease. Without this, what Sunny and myself have seen, unfortunately, a number of times are kids who come to us too late, because other than the liver disease, these kids are generally well. They are often growing. They look well. And the stool color is always difficult sometimes to be firm about. So I would argue that if you are 2 weeks, especially if you're 4 weeks of age and still jaundiced, it warrants a blood test to confirm the fact that there is nothing that needs a specialist.
And Sunny, any last takeaways from you?
I think my big takeaway would be this isn't hard. This isn't supposed to be a burden. In fact, this is a wonderful, special opportunity for primary care doctors and specialists to work together like we did in medical school, like we did in residency, like we continue to do as we pursue our careers. This is a step 1, step 2, step 3, check eyes, then stool, then first Billy. Even though it's a complicated disease, it's a high impact disease, the collaboration between primary care doctors and specialists can really change the course of a child's life. And so I'm excited to have this chance, and we're all excited as specialists on this side to have this chance to work very closely and continue to work closely with primary care physicians.
Well, Drs. Harpavat and Karpen, thank you so much for joining us today with this important report.
Thank you.
Thank you. Thank you for having us.
To read the new clinical report, Identifying Infants with Biliary Atresia by 2 to 4 Weeks of Life, Guidance for the Primary Care Provider, visit our website at aap.org/podcast.
Coming up, we'll look at variations in pediatrician work hours.
Joanna, I know for a fact that you're a hard worker.
David, it takes one to know one. But what I don't know is how many hours a week you spend at work. In fact, I'd have to think some to figure out that for myself, given work extends out of the clinical space for me.
And what about our pediatric friends and colleagues? I wonder how many hours a week they work. I mean, plenty, I'm sure.
Well, I know 2 hardworking pediatricians and researchers who may have a better idea, Drs. Gary Freed and Bobbi Byrne. You may remember them from earlier this year in episode 230, where they joined us to talk about pay discrepancies by sex. Now they've written another paper in pediatrics, Pediatrician Work Hours 2013 to 2022.
Gary is a former attending of mine at Chapel Hill. He's currently the Percy and Mary Murphy Professor of Pediatrics at the University of Michigan Medical School, where he also serves as Policy Director of Research in the Office for Health Equity and Inclusion, Director of the Michigan Child Health Improvement Collaborative, and Director of the Program on Equity for Adolescent and Child Health.
Dr. Byrne is joining us from Indiana, where she is a professor of clinical pediatrics at the Indiana University School of Medicine and the vice chair of education in the Department of Pediatrics. Bobbi and Gary, welcome back to the show.
Thank you for having us.
Yeah, great to be back.
And if it's okay, Gary and I are happy to take credit for many, many things, but we really do want to call out that our colleagues at the American Academy of Pediatrics, Bill Call, Mary Pat Frittner, and Tyler Kist, were instrumental in this study. So we're here just on their behalf.
Even more than instrumental, they were, the drivers and leaders, and we're thrilled to be able to further promulgate their great work.
Well, thank you so much for coming on to speak about this work. And as pediatricians, we are super curious about our peers' work hours and how that might affect their quality of life. What were the specific questions you were hoping to answer with this study, Bobbi?
Yeah, like you mentioned, we were really interested in seeing not just how many hours people worked, but that was important, but how that changes over time. And the last time Gary and I were on, we talked about the longitudinal nature of this study and how it's very unique so that we can really see a group of pediatricians, how their work hours have changed over a 10-year period, which is really interesting. But also, we wanted to know what percentage of the pediatrician work hours are spent on direct patient care, and how different is it in the total hours worked versus direct patient care hours? And then finally, if pediatricians who are working fewer hours, or if pediatricians who work a lower percentage in direct patient care have a better work-life balance. So those were some of the things we were looking at in this study.
And then on top of it, we also wanted to look to see, because everybody talks about differences in male and female pediatricians, and we wanted to see what was the reality in terms of how many hours per week different people work. Did that change over time? And as Bobbi mentioned, did the number of direct patient care hours differ markedly between men and women pediatricians?
So to answer these questions, you turn to this database called Places that's maintained by the AAP itself. Gary, what makes the Places data so ideal for looking at work hours?
What makes Places unique is the fact that there's 3 different cohorts of people within Places at different times within their careers. And so not only does Places maintain an annual or sometimes twice a year update with the participants, but we can also follow different cohorts over time. So we have older pediatricians, what might be nicely termed middle-aged pediatricians, and younger pediatricians, and we can see how those careers are playing out depending on what year they entered the workforce.
And I'm so glad you broke that down kind of into different categories, because that's how we wanted to look at the results with you. And I'd love to start with gender. Most pediatricians are women. Did you find a big difference in work hours between women and men?
One of the things that we found in the study was that there was a difference in total work hours, with men working over 7 more hours per week than women in our current study. However, we know that pediatrics is a specialty that allows our colleagues to have some flexibility with their work schedules. And in fact, working part-time is one of the hallmarks of being a pediatrician that we have provided as a work-life balance for our colleagues. And so we expected to see that our male colleagues were working more than our female colleagues in general.
And also we were able to do during the study is to see if that differed among different kinds of pediatricians. So we found the bigger differences between men and women among general pediatricians and pediatricians in what we called the smaller subspecialties. That's where the larger differences were, like Bobbi was saying, 6 or 7 hours difference a week. And that's just for direct patient care. It got a little bit bigger when you added all the other indirect patient care as well. But for hospitalists and for the larger subspecialties, the differences were probably half as much. So this gender difference in the time we spend at work actually varied by what kind of pediatrician you were.
And then let's look at age as a variable. I have heard rumors of doctors slowing down with time. Is that really a thing that happens?
Yes, not a ton, not as much as you might think. It was only 1 or 2 hours a week, usually amongst all of the different types of pediatricians we were looking at. Now, it could be that we're just not following people long enough yet. And the beauty of this Places data set is we'll continue to follow these doctors into their later 50s and 60s, and we're not quite there yet. So that hypothesis is something that we'll hopefully be looking at 10 years from now, and we'll be able to see, do those changes manifest themselves at even a greater rate as people get older?
How do subspecialists' work hours really stack up against general pediatricians? Bobbi, do you have any insight into that?
Yeah, one of the most striking things is that the subspecialists tend to have less direct patient care time and more time in other activities such as research or education, teaching. And I don't think that we're surprised by that, but it's a significant difference between general pediatricians and subspecialists. I think what's more interesting, in my opinion, is that the people who have more direct patient care had higher satisfaction rates and better work-life balance. And so what that tells me is that, and what we hypothesize, is that perhaps things like teaching and research can be just as taxing as the direct patient care challenges that we face as pediatricians.
And speaking of issues like teaching and research, what effect does administrative work have on people's hours? Does it take longer than seeing patients?
It was similar to those who were doing research or teaching, very similar. I would group that in with those other two activities.
And I think that on top of that, part of the reason that we hypothesize that we see those non-patient care activities much higher among the subspecialties is because those are much more likely to be academicians. And the general pediatricians, the vast majority of whom are in practice. So it just makes sense that they're going to be, on average, spending more time in direct patient care.
And let's get back to that first question about work-life balance. I feel like that's such a big consideration for so many of our peers. It's certainly for me. What can we say about this when we look at this study?
Well, certainly it's a really important issue that's on everybody's mind. And drum roll, it turns out that the more you work, it definitely can have an impact on your satisfaction and your work-life balance. Time is a zero-sum game. And as much as we are dedicated to our patients and we care deeply about all the different aspects of the work we do, there's a toll that's paid. And there is an association between increasing work hours and a decrease in work-life balance, and at times professional satisfaction.
It's funny, though, wasn't it, Gary, that we saw that certainly while lower work hour groups reported better work-life balance because they reported having more flexibility or more time for their children, for example, none of the pediatricians in the study reported adequate time for themselves. And so that was another interesting finding, in my opinion.
Agreed.
That is a fascinating finding that's going to make us all introspect here for a minute. I'd love to hear what each of you would pick if you had to choose one takeaway. Dr. Byrne, you want to start?
I think as an academician myself and somebody who is an educator, it was somewhat reaffirming to me to see that some of the things that I do outside of direct patient care, and I love my direct patient care hours, but I do administrative, I do education, I do research, and that those things really might be just as, I certainly know that we all know that they're just as important as direct patient care, but that they might also be as taxing as direct patient care. And I found that to be rather validating, truthfully.
I love that. Gary, what about you?
I was actually surprised that the gender differences in the groups we looked at differed by the type of work pediatricians did. I thought that many of the gender differences in work hours we'd actually see to be consistent across all different aspects or all different groups of pediatricians. But in fact, that certainly wasn't the case. And it does appear that that flexibility that Bobbi spoke about is certainly more manifest in general pediatrics than the other groups. But those differences narrowed considerably and many of the other types of pediatricians that are out there.
Well, Doctors Bobbi Byrne and Gary Freed, thank you so much for joining us today.
Thank you for having us.
Yeah, it's great to be back.
To read the study, Pediatrician Work Hours 2013 to 2022, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
So a little background, my roommate from college is an anthropologist who now co-manages a gallery of antique Japanese art. And for years, he has sent me and Christy an invitation to his shows so we can see what he does. And we have never been able to go. But this last weekend, we finally went. We went up to the Nippon Club. I didn't know they had a club in New York. And we got to see these incredible artworks and antiques that he deals with and got to see him in his element. And I'm just so proud of him and so glad that we got to do that.
That's so fancy, David.
It is, yeah.
My Say Ah is that Simon can now crack an egg.
Oh, right.
Like, he used to crack it, and then I would have to open it for him, you know, but now he can open it. And, like, sure, like, little shells get in there, but, like, you know, it's pretty huge. Now, he's, like, one step away from making his own breakfast.
Nice. Way to grow a little chef there. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss environmental issues in global pediatric health.
We'll talk to the author of a new policy statement, Dr. Philip Landrigan. I'm Dr. David Hell.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.